Very good to see everybody this morning and the folks out online. For people who haven't met me, I think I've met almost everyone, but I'm Pat Danaher. I'm joined the faculty here at the VA and USF in August. Feels like it's been more than 3 months with all the hurricanes, but so new to Tampa, but was in the military for 25 years before that, and then the San Antonio VA for about 6 years. Glad to be here this morning with you all. This is a new talk that I put together. I've made it very case focused, so I'm hoping we'll have some good discussion as we go through it. A couple disclaimers up front. These are my views and my thoughts, not the government's views and thoughts. And I try to get rid of all commercial product names, but if they sneak in there, don't interpret that to mean that the U.S. government endorses them. That's not true. By way of overview, we'll start with kind of some high-level categories and useful schema that I think you can use to look at questions on the boards that pertain to dermatology. We'll go through some cases and then a summary at the end. So in terms of infectious agents going from smallest to biggest, I find it's useful when I'm thinking about a differential diagnosis to kind of think back to this rubric going from prions up through ectoparasites. There will be at least one ectoparasite that we'll touch on here. All right, so this is back from the 1990s, early in the HIV/AIDS epidemic, and this was a slide that I think was more useful in the past, kind of pre-antiretroviral therapy, but still it can be useful. And you'll see the middle column there has got dermatologic diseases based on CD4 count in terms of which are more prevalent at what point. Now that we see many people on antiretroviral agents, you can see some of these diseases that we didn't see at higher CD4 counts. You can see still. I think the important thing to think about on this slide is the fact that not every patient reads the book, and so you can have diseases appear at CD4 counts you might not expect them to appear at. But overall, useful to get you in the right neighborhood when you're seeing a patient with a dermatologic finding. This is another similar rubric that I put in just for you all's consideration in the future if you want to come back to it. All right, we will jump into the first case here. Back here. Yeah, so she's had 72 hours worth of fever, sore throat. She says she's had over the past 6 months these 12 mostly anonymous partners. So, yeah.
So all of it should be positive.
Should be, but that's not your choice. Your choices here would be, and we'll I think I already let the cat out of the bag on this one anyway. So the point here is to kind of bring home some teaching about how our testing algorithm works, and we'll jump on to the next slide here that does that for us. This is, you guys probably recognize this from the CDC's recommended testing algorithm. And the point is that our 4th generation test, which is the P24 antigen plus an antibody test, by 4 weeks after acquisition of infection, about 95% of people will have a positive 4th generation test. By the 6-week mark, 99% of people will test positive. By contrast, for the viral load, the HIV RNA test, within 5 days for some people, and by 8 to 10 days, all should be positive. And so when you're seeing somebody with acute retroviral syndrome, which is what this woman had with the rash that goes with acute retroviral syndrome, it can be early on after acquisition, and you might have what her pattern was, which was a positive 4th generation test, negative differentiation test, and then the PCR was positive. So that would not be uncommon. The other thing you may get called on, depending on where you work, is to weigh in on how your facility implements this testing algorithm and recognize there are 3 FDA-approved viral load tests, or not, I keep saying viral load, there are 3 FDA-approved PCR tests for diagnosing RNA or diagnosing HIV. You need to know what one your facility uses because it may or may not have an FDA indication for making a diagnosis. We use it clinically kind of the same way, but 2 of them are qualitative and only 1 is quantitative. And by way of how often would you see a rash with acute retroviral syndrome, acute HIV? It's about 70% of the time. So it's kind of in the top 5 in terms of findings that you would see with acute HIV. All right, you can take this one.
Sure. 36-year-old cisgender man, HIV, viral load undetectable, and CD4 count 450. That's with complaints of bees, painful lesions on his penis and scrotum. They appeared about 5 days ago. says they're getting worse.
What do you think's going on here?
They look like pustular lesions.
Yeah, so vesiculopustular, I think you could say. The top ones look a little more, they're a little ulcerated, already starting to get some adherent kind of scab to them, and the bottom are kind of more fresh. To be fair, this is not from the same person. These are lesions at different stages here. So, which of the following would you recommend treating this with? This is tricky, right? Like, I'm not giving you a lot of drugs on there that look pretty good.
Yeah.
So there must be something else I'm getting at.
So it's a good. So the Acyclovir is gonna be twice a day. So it's not A or D. Acyclovir is most likely the right answer here. I'm not sure about the 400 milligrams versus 800 milligrams. But not sure about the Acyclovir. I'll go with C.
You like C, and I would agree with you. And that's exactly it. I was trying to, and the board is not often this sneaky with you in terms of getting to time intervals, but you're right to be thinking about what's the dose and what's the interval. And valacyclovir, I think, is what we're all most used to using, and it's usually a gram twice a day. The acyclovir, some of the healthcare systems you would work in will require you to use it because it's less expensive and a little more of a hassle for the patient because it's multiple times a day. But for a recurrent episode for HSV, it's usually a 5 to 10 day course. For a first episode, usually 7 to 10 days. And you'll notice as you compare the varicella zoster virus to the HSV virus, you can get away with lower doses of acyclovir, the acyclovir compounds for treating HSV than VZV. All right, so who wants to grab this one?
That slide that I see.
You can see
acyclovir 400 3 times a day.
I've
seen people treat zoster with that.
Which is
zoster
not enough.
So,
Not enough.
I don't.
All right.
Year-old transgender woman with HIV viral load of 170. Presents painful relesion from her anus at the belt. Has taken oral acyclovir in the past, but so on episodes started about 10 days ago to know the diagnostic test.
You think? What test do you? What's that? So this sounds a little bit like the last case, right? In terms of lesions. So, and she's used acyclovir before and restarted it, and it's not getting better. So you want to do a
HSV and PCR.
So PCR, and that's kind of what I was getting at here. Is this is what most of the time, like 90% of the time, PCR is right. If you're looking at a lesion and trying to figure out is this HSV or VZV, that's the right answer. In this case, the kind of tips in the stem are that she's had multiple courses of acyclovir before. She's been on acyclovir for 10 days now. It's not getting any better. And so there's concern about acyclovir resistance. And you couldn't tell that from a PCR. So you need to do a viral culture test. So you'd collect a swab. She would submit it for culture. All right. So, and it's going to be the same. This is the same thing I did to you last time. So now you already know when it's HSV and it's probably resistant. So which of the following statements is true regarding acyclovir resistant HSV in persons with HIV? You guys like D, You're not falling for any of the other potential agents? Nobody likes topical or high dose? Topical that I've never used.
I've never used it.
I've seen Dr. Green's likes to use that often.
Yeah.
Used to use.
All right.
And
I've never
now, hopefully soon you'll have helicase primase and which would be probably the go-to instead.
So yes, for the time being,
But for now,
IV-foscarnet is
you don't have it.
what we've got. So let me ask you this. You put her on IV foscarnet after all her lesions resolve. Should she be placed on suppressive therapy with acyclovir? I'm going to try to convince you otherwise, Kurt, but I'll do that by showing you this slide. So as you look here, the way acyclovir and valacyclovir work when you take them, valacyclovir gets converted to acyclovir, and then a thymidine kinase within the HSV virus phosphorylates the acyclovir, and then actually the mammalian, our cellular kinase, adds two more phosphates, and then that is a chain terminator for the HSV DNA. It's basically a nucleoside analog. That's what acyclovir and valacyclovir and famciclovir are. And so the way that HSV evades acyclovir is that it downregulates the thymidine kinase. And so if you never get the initial phosphorylation, you're never going to get the second and third phosphorylations, and HSV can replicate to its heart's content. In general, the approach to these patients, usually when you see acyclovir-resistant HSV, it's going to be in late-stage AIDS patients who've been on recurrent multiple courses of acyclovir and have very low CD4 counts. You treat them with foscarnet until the lesions all resolve. And I dare you to put in that call to Dr. Canella to let him know you want to send an OPAD patient on foscarnet and ask him to just keep an eye on him for you. You treat them until the lesions resolve. And then this is, I think, a really interesting point, is that there's lots of clinical data showing that putting them on acyclovir suppressive therapy after you finish the foscarnet results in fewer further recurrences. And I love that. That's kind of how your face ought to tie up in a knot. Like, why would that work? And it works if you think about the reservoir of HSV in the body. And so when you look at recurrences, you're more likely to have a recurrence with acyclovir susceptible strain than an acyclovir resistant strain. So if you remember, the HSV DNA doesn't incorporate in our DNA, but it does hang out in the nucleus of our cells and waits for a chance to go from latency to reactivation. And you don't know what you're going to get with any given outbreak. And statistically speaking, it's more likely to be a strain that remains susceptible to acyclovir. Even putting all of that biological plausibility aside, the fact is there's lots of clinical data showing that if you put people on acyclovir suppression, they have fewer recurrences. So you would want to put her on suppression. By way of overall your approach to people with recurrent bouts of genital herpes or herpes in other areas, it's kind of like very squishy in the guidelines. They say if they have severe episodes, you might consider suppressing, or if they have many recurrences and don't want to have any more recurrences. I kind of stick in my head with, you have two options. You can put them on chronic continuous suppression, or you can put them on episodic treatment. For those who I do suppression with, 3 or more episodes in a year, or really in a bad place. I took care of one poor person who had an HSV2 lesion that came out on her forehead every month with menses. And it was like just miserable, like every month was a disaster. And if it's, it's one of those things where I say, like, you'll know it when you see it. When you see people, in the conversation, most people will steer you towards whether they want chronic suppression or episodic treatment.
Patients will ask for it.
Yeah.
The foscarnet patient, we keep them inpatient until the.
I was being tongue in cheek. If that's the only thing keeping them here, you might try to get them to a facility, but you're going to have, because of the renal toxicity and the electrolyte abnormalities, you may very well be stuck. Yep.
So in summary, this foscarnet patient, you would?
Put on acyclovir, correct.
Yeah, okay.
Yeah, you'd finish your foscarnet and put them on suppression, and it's important because it's counterintuitive. Like,
right.
That's not what we normally do.
That's why I have to repeat it.
But if you think about it, like we do this with other disease entities too, recurrent UTIs, a homeopathic dose of cephalexin at bedtime will prevent a lot of UTIs, even in patients who have had cephalexin-resistant gram-negative rod UTIs. So there's other places where that rule works, but yes, foscarnet, after you treat somebody with acyclovir-resistant HSV with foscarnet, you put them on suppression with acyclovir or valacyclovir. Yep. All right, who wants to take this one?
Started 3 days ago. Physical exam, she has a vesicular rash. She has no systemic symptoms.
So what do you think this is? Zoster. Yeah, I agree. And they're not going to ask you the diagnosis. They're going to say, what do you want to treat it with?
2 steps.
You like B? Yeah, I agree. I agree with you.
Prednisone's not necessary.
No, and in fact, basically, in HIV, the guidelines would say that for HIV patients with dermatomal zoster, you should avoid prednisone because of the risk of additional immunosuppression. When you look at people without HIV and zoster, they recommend a pyramid approach to pain control. So everybody should get offered acetaminophen and NSAID, and then kind of the next step would be to think about prednisone, and then after that might be opioids. This is one where I think probably the amount of immunosuppression in many of our HIV patients, I think they do fine with prednisone if I really thought it was going to help them in this situation. But the guideline answer is no, don't give prednisone to patients with HIV and dermatomal zoster.
Gabapentin.
Yeah.
And gabapentin is also in there. I've missed that step in the pyramid. That actually comes before prednisone.
Wait, I thought that's for subacute herpetic neuralgia and acute herpetic neuralgia, right? Those first 30 days, simple analgesics.
Yeah, and you can use gabapentin. I'm with you. It's more of a chronic. We think of it more of as a chronic treatment. It is in the guidelines that you can use gabapentin during the acute neuralgia with zoster.
Pretty well put
Yeah.
together for
Correct.
the chance of EHN is much less if you can get it seen and diagnosed within 72 hours, maybe up to.
Right.
And that slide shows you exactly because you need a prodrug to get adequate levels for zoster.
Right.
You can try and get them, but remember, if you're going to give me acyclovir, it's 800 milligrams
5 times. Yes.
So if you don't like the patient,
Yeah. Yes.
Versus the Valtrex is still
Twice a
twice a
day.
day.
Twice a day. Yeah, 3 times. No, I'm sorry. It's 3 times.
Three times.
That's
That's different.
three times a day, and there's just a large amount.
Yeah.
There's not a chain terminator.
Yeah. All right. So, in the spirit of not making things easy, what do you guys think about this one?
This is a great question.
Yeah, and to be fair,
You guys, I'm so sorry. We lost audio on this end. Just FYI. Sorry. Great presentation, by the way.
Hello? Hi,
Yes,
can you hear us
now.
now? Okay.
all right. Hopefully we're back.
Yes.
Yes, we're back.
Very good.
It's working.
All right. So what I was saying is there's 2 ways to basically say D is the right answer. Well, the easier way in this case, I think, is if you're working in a family medicine clinic that takes care of pregnant women and neonates, that's a good reason to say to exclude her from caring for those patients. The other way to think about it, and I tell you that whoever wrote this at the CDC is getting a lot of mileage out of it. If you look, this is the guidance for how you decide who to vaccinate for COVID, like who's at highest risk for getting COVID disease and what treatments we'll use for COVID. That's where this table resides, is on the COVID website at the CDC. And it's their list of moderate and severe immunocompromising conditions and treatments. And it's to help you decide who's immunocompromised enough to get which treatments for COVID. They also used it in the RSV guidance, the RSV vaccine guidance, to say who's immunocompromised enough to think they might benefit from the RSV vaccine over age 60. And it's the best thing I could find to look at for would I consider this healthcare worker immunocompromised or not? And they kind of define it as a CD4 count less than 200 or AIDS defining illness. So I would make an argument that she's probably not too very immunocompromised, but I would probably exclude her from care based on the patients she's taking care of. That makes sense. But you realize these decisions are going to bother people because that's her livelihood. She may need her paycheck and she's not going to be happy that she's got to sit out work for a while because you're recommending she be excluded from care to protect high-risk patients. All right. What if who wants to take this one? So what do you guys think that is? The umbilicated lesions, is it a few or a bunch? Yeah, some of them like coalescing. So yeah, you're thinking, yeah. So his HIV antibody antigen test is positive. The differentiation assay shows HIV-1. He's got a CD4 count of 3 and a viral load of 5. So which of the following is the recommended first-line therapy for this man's skin lesions? There you go. Yeah, and that's it. So molluscum is kind of like, you'll hear me use this algorithm or this analogy a lot. It's kind of like the Marine Corps, many are called, few are chosen. Lots of people in the general population will have a molluscum lesion or two over the course of their lifetime. When you see coalescent molluscum, particularly on the face, is a prominent area to see it. That ought to be a red flag to send an HIV test. And treating with antiretroviral therapy will work. For people who you can see an iris type reaction, and these things can get worse initially when people start immune reconstituting. If that happens, or if they don't get better with antiretroviral therapy, there are topical therapies that you can send them to dermatology for.
People shave. I will inoculate on the face.
Yeah. Oh, yeah. Yep. Yep. Have advanced disease like that, yes, there's a correlation. The lower the CD4 count, and in fact, there's even under 50 something called giant molluscum, which is like a huge coalescing bundle of pox virus.
Oh.
Speaking of which, pox viruses may be a good thing to keep in your mind. In this case.
Annual MSM with HIV on ERT, recent CD4 count 765, viral undetectable. Presents with this painful rash that are 10 days after engaging in condoms receptive anal sex with multiple partners or party NYC. Sounds like healthcare. The rash began in his perianal region and since spread to multiple parts of his body. Oh, he's on infliximab for inflammatory bowel disease. Come to the ED because the new lesions continue to appear and the pain has become intractable. Stop eating and drinking at home due to pain with defecation.
And here's some of his pictures.
So what diagnosis do you suspect? I think Mpox would be one of the top.
I agree.
The pain.
Diagnostic
Test choice. Swab lesion.
Yeah. And PCR.
Right.
100% PCR.
Cautious to be airborne.
That's a really good point. So funny you would say that because that's what I would have said. But it's not. And in fact, when you look, the CDC just put some new guidelines out in September of this year, and they've made it align quite a bit. It reminds me of COVID for that matter. It's basically contacts, gown and gloves, plus iPro, plus N95. So it is, but you only need a private room. You don't need negative airflow there. They specifically go out of their way to say no specific airflow requirements necessary. And I think it's because the bulk of the transmission in most patients is going to be contact. It's going to be contact and droplet in the extent that droplets that don't travel very far. The question becomes, like, for this person, do they have viremia? That's the question in my mind, at least. They probably do, given that this is actually a patient I saw who was not this patient. I made up the stem and then put these pictures with it. This is a patient I saw with atopic dermatitis who had Mpox, but that's a lesion on the chin. There's a lesion on the thigh, on the hand, and the foot. So to get lesions that widely distributed, you have to be assuming she's viremic, and then you have to wonder about her exhaling virus particles every time she exhales. So maybe there might be sometimes, but the textbook answer, like on the board exam, is not airborne. And I think, isn't the CDC getting ready to reissue all of the contact-based transmission precaution guidance? Yeah, it's coming. It's like it's in the review phases. Yeah. So N95, iPro, gown, gloves.
This makes it confusing, especially during the peak time of COVID, because essentially it was labeled as airborne and then moved down to like contact special droplet. We call it special droplets at PPH.
Yeah.
And whenever there's an N95 involved,
Yes.
I guess as residents, before I became the ID, automatically assumed if it's N95, it's airborne.
Right.
So that's what still is confusing.
And part of this is because we're all confused, because honestly, what I learned 20 years ago was that everything was discrete. Here you had respiratory droplet, here you had airborne, TB, varicella, disseminated varicella. These are things that are lighter than air. They float on air currents, and you need a negative pressure isolation room. The truth is, I think it's a spectrum. You have, for each different infection, like influenza is more towards the respiratory droplet. Is there ever some airborne transmission? Probably. And for COVID, probably even more in the middle than influenza in terms of between respiratory droplet and lighter than airborne, 5-micron particles floating on air currents. So I think it's in flux because we were basing it in some cases, not so much on epidemiology as on tests you can do in a lab, kind of like mechanical tests. We're now basing it more on the epidemiology. So where do you see cases? So measles is one where it's so airborne. Like I think the R naught is like 25-ish for measles. Like it's certainly cases are transmitted through air ducts to people in a totally different part of the hospital if you don't put them on airborne precautions. So you're not the only one confused. But the answer on the test is the answer here at the VA is call infection prevention.
Okay. Don't call us.
You want to be savvy about it, and you want to reinforce the infection prevention people. I see. So that as the infection preventionists are telling the people on the floor, this is what you need to do for this infection, you want to be in lockstep with them. But you don't want to get into a chart war where you're like, I said this person needs airborne, and infection prevention comes and says, no, they don't need airborne. This is what they need. It's good to be on the same page with them. And oftentimes, like, you can negotiate pay for that. If you're the medical director for infection prevention at your hospital, you can get like a 0.1 FTE paycheck for doing that. So you want to know about this, and you want to work well with your infection preventionist to make sure you guys are sending the same message.
Game the system. If they talk infection control,
I
don't like what they say, they'll call you.
Yeah.
Say something
Exactly.
different. My first line was always, have you talked to infection control?
No.
Because I'm going to call them.
Yeah. Correct.
And if you like to monitor study, Dr. Morano wrote MTV, not music television, measles, TB, varicella.
Airborne.
Yeah.
Yep.
Hard.
I like that.
Uh-huh.
Thank you, Dr. Morano. Yes, it's gotten easier now because it's really it. It's those three.
Thank you for that. Spectrum thing makes a lot of sense now that you maybe think about it that way.
Yeah.
It's insane. There is this one study that was done in West Virginia where they monitored for PZV outside of a patient's room at Zoster and said, we can detect viral particles outside the room. So really, they should be in airborne. No, because people are getting infected.
Yeah. Right. That is a real pearl to take home, is that your decisions on infection prevention should be based on epidemiology, not on microbiological tests. So just because I put a sensor or a detector or a culture plate in the hallway and found something doesn't mean it poses a threat and you're going to have disease transmission. All right. So of course they're going to not ask you what the diagnosis is. This is going to be your question. What do you guys think?
C.
Okay. tecovirimat. So, or Tpox is the trade name. In a nutshell, none of which one of these is easy to get? Which one of these is not controlled by the federal government, and you could probably get it in this hospital today if you wanted it? A, correct. Cidofovir is available. It would be an off-label use, but if you had a severely sick, like this guy was bad, right? He's got new lesions appearing. He's in so much pain. He's not eating. He needs treatment. You want to get him treatment. Tecovirimat, I don't know if you guys went through the rigmarole to get it here. For the oral, there's a clinical trial, STOMP trial that's ongoing. You have to work with your local health department typically to get that. For the IV, and if the patient refuses to participate in the STOMP trial to get the oral, you have to go through an IN process. The Cidofovir is available from the maker of the product. You would have to coordinate with them to get that. And then the intravenous vaccinia immunoglobulin is available from the CDC. The point is none of these are easy to get. Kind of like malaria. Like if I'm waiting, took me for the patient I saw, it took us like 36 hours to get the tecovirimat there. So I didn't give her a dose of Cidofovir, but I thought about it. It's kind of like malaria, treat with what you got. If I don't have any IV agent available, give them some Malarone. If I got that on the shelf, you could make an argument, I think, sometimes to use
That's
some.
exactly what happened in our recent malaria case here.
Just to add to, for those of you who've been paying attention, there was that, speaking of Mpox, there was that first ever case of clade 1 disease reported in California from a gentleman who had traveled from Africa. So maybe
Just recently, right?
just reported in the last week.
Last week,
Maybe
right.
seeing
And,
more Mpox in the U.S.
and I'm running out of time, so I'm not going to belabor it. I was going to talk here a little bit about there is tecovirimat resistance now. So
Yes.
Microbial stewardship week, like to mention that particularly in people with advanced HIV who got long courses of tecovirimat, the virus does have resistance to it. So there are resistance cases or resistance. You could see resistant cases now. All right, we're moving out of the virus and into bacterial pathogens. What do you guys think about this one?
21-year-old cisgender man with HIV seen in clinic for evaluation of this painful lesion has had 2 similar episodes within the past year. An incision and drainage of the abscess is performed for pathogen. Participant will be isolated and cold.
I love these episodes.
Bacillary.
What's that?
It's Bacillary angiomatosis. What was that?
Would it be 3 times? Then would you IND? Yeah.
Like,
yeah.
So what I was saying, this is the what am I thinking? I guess this is more of a what am I thinking question. So 3 recurrences within the past year, they get better with INDs. So I'm aiming towards what's the most common bug, you guys?
Staph.
Staph. And in MRSA in particular.
Overthinking this.
Yeah. That's what I'm telling you guys. Comments.
MRSA in particular is what I'd be worried about. And what do you guys think in terms of which of the following statements is true, which means it's a fancy way of saying the other 3 are not true. Yeah, A is correct. Yeah, multiple sex partners and drug use are independent risk factors for MRSA infections. The rates are actually similar between those. I should say the risk of recurrence is higher for those with HIV, and you can definitely see it in people with higher CD4 counts. And certainly you can use Trimsulfa to treat it. It's not going to be a problem. All right, now, Kurt, you were reading ahead. This case is going to match what you were looking for.
Cisgender man with HIV and a CD4 count of 66 cells because of the clinic evaluation for several of these painless purplish nodules on the right arm. There we go. Multiple stray cats. He's not taking any medication. No systemic symptoms of exam. Other than what diagnostic tests would you recommend? Diagnostic tests. So it's like antibodies. I don't know.
So that's probably what you've seen the most here in terms of like looking for bacteremia and those kind of things. But what you're going to want here is a biopsy. You're going to ask derm to biopsy this. And in particular, when they look under the microscope, you're going to ask the pathologist for a specific stain.
Warthin starry stain.
Warthin starry silver-based stain. And my mentor for many years used to call it the worthless starry stain because it's very rarely helpful. But in this case, let's say the guy had the biopsy and the worthless starry stain was positive for gram-negative bacilli. And so you've now made your diagnosis of bacillary angiomatosis. And how are you going to treat that?
Angiomatosis.
What do you guys like?
I know it's not B or C.
I like
That's
A
wrong.
and D is not necessary.
All right. So D, the point is with bacillary angiomatosis, it's going to be long. It's HIV, bacillary angiomatosis, it's going to be long, and it's going to be at least 3 months. The other ones, I'm throwing you some curveballs. So azithromycin for 5 days, that would be for cat scratch disease in an immunocompetent person. This is the difference between like what's the most common and then what's going to show up on the board because it's classic. Like bacillary angiomatosis will probably show up on the board. What will more likely show up in your clinic is cat scratch disease in an HIV patient who's got a preserved CD4 count, and them you can treat with azithromycin. That's okay to treat them the regular way. C is for the eye, and B is for liver and spleen in immunocompetent. Those are in immunocompetent patients. Another interesting thing is that although Bartonella can cause neurological disease in immunocompetent people, it is rare in patients with HIV. Just don't see it very often. So, all right. Who wants to tackle this one?
Bacterial syndrome AIDS for months, with 60,000 usually hypertrophied skin, the scaling most pronounced on his extremity, although it's very cryptic. Initially says it does not itch now. On exam, we notice crusting and fissures along with intense malodor. CBC is notable for AEC of 1500. That's what diagnostic test would you pursue?
Do you need a diagnostic test?
What do you guys think?
A skin scraping?
Yeah, so you're going to do a scraping, or you can do a scraping, or you can do dermoscopy. And this is basically the right picture here. This is scabies, and the right picture is you can see a mite up in the upper right corner. You can see some eggs lined up in a nice row down there, and above the eggs are the feces. So this is a scraping. And then the dermoscopy is in the bottom picture, and you see the triangular head of the mite there. So how are you going to treat this person? T, yeah.
Gabe is in my closet.
You need both. You need IV, or you need the oral, you need the systemic and the topical. And I'm not going to belabor the other topicals. We'll move on. So, of course, here's another bonus infection prevention question for you.
Oh, yeah, see these isolation thing. True.
Yeah, so there's an entire, the CDC was kind enough to write an entire guideline on how to manage scabies in healthcare settings. The bottom line is you're going to need to set up the first thing you're going to need is a surveillance system to screen your current patients on the same shift, the healthcare workers, and those kind of things. The bottom line is there's guidance out there. This is another time, though, where you're seeing the person in clinic and you have to think, what are the second and third order effects? My son, I got to take it aside for a minute, but he's working as a scribe for one of my friends in San Antonio, and they just had an AIDS patient with scabies that they treated like a month ago who just came back. He had two different patients with scabies. One of them is getting much better. The other one doesn't look much better. So they're sending him to dermatology, but he itches. My son itches for like a week after he sees. He's like, Dad, that's, I'm like, yeah, unfortunately get used to it. It'll happen.
When I was a scribe, I would stand at the door with the patients. I would and just chart.
All right.
One guy that had it on his face.
Yeah.
I mean, just got to keep treating until it finally comes loose. When it came loose, it had a cast up into its inner ear. That bad.
Well, and the thing is, it's the pure mite burden. So an immunocompetent person may have 10 to 15 mites is it on their body. The pictures I showed, that's millions of mites that are in that area. All right, I want to take a look at this one.
34-year-old cisgender man with HIV returns to clinic after 1 year absence. He has not been taking antiretroviral therapy for at least 9 months. CD4 count is now 210. On exam, several non-tender purple nodular lesions of the upper arm region of chest. They have growing slowly for 2 to 3 months. He has no systemic symptoms or edema. What diagnostic test would you recommend? Biopsy.
Biopsy.
Yeah, so you do a biopsy to confirm that it's, what are you suspecting? Yeah, so we got to the apex infectious agent. We're past ectoparasites. We're into neoplasms now, and yeah, so Kaposi sarcoma. And so you do a biopsy. The biopsy confirms
Spindle cells.
that you've got spindle cells. And what's the viral association there?
HSV.
HHV8. And then what's the other test you would want to do up front for these folks?
Say one more time.
What's the other test you'd want to do up front along with your biopsy? To help you determine, I'm throwing you some things in here, like he doesn't have any edema. I think I put that in here. Hopefully I did.
Right.
Yeah, no edema on exam. What's the other thing in terms of pick and treatment that you got to know? So you've proven by biopsy what's going on. And then the other thing you'd want is a chest x-ray to make sure there's no pulmonary involvement.
Yeah.
And then that should be enough to let you pick a treatment. Actually just A. So if you have just dermatologic disease, there's no evidence of any kind of dissemination or visceral involvement, then you can just start them on antiretroviral therapy, which is what I wanted to point out. If it's derm-only Kaposi's, antiretroviral therapy. If you need to do your due diligence to look for any evidence of systemic involvement, which at the minimum would be doing a chest x-ray, looking for a lot, because if you have severe skin disease, or if you have systemic involvement, then you guys are 100% right. You need chemotherapy to go with it. All right, moving on to some skin cancer. Common things are common. Just the patients as we're seeing them in clinic are at much higher risk for having run-of-the-mill skin cancer. So basal cell, squamous cell, melanoma, all somewhere in the 2 to 5-fold increased risk. So you have a chance to help them in that regard every time when we see them. And then you see some kind of unique skin cancers in them with respect to HPV genital in situ and invasive SCCs of the genitals. All right, we're getting close to wrapping this up. What do you guys think about this case?
44-year-old male with HIV, CD4 175, viral load less than 20. Termsulfa for pneumocystis prophylaxis. Presents with fever, sore throat, dry cough, nausea, diffuse maculopapular rash. 2 weeks after being switched from bictegravir, emtricitabine, tenofovir, alphetamide to dolutegravir, bacterial, due to his aggressive CKD.
Interesting. So he was switched from what?
From a non-abacavir regimen to an abacavir regimen. That's the
From
thing that made.
Yes.
Try that, right?
Yeah, this is the only one I've told you what the art was. Otherwise, I just told you it was art. So,
Yeah.
all right. So what are we going to do next?
I want to stop the abacavir.
Excellent. Yeah, I agree with you
I
completely.
don't think we need an HLA. Probably going to be positive.
Yeah.
You know,
Maybe you should have had that.
maybe should have had that before.
Yeah. Too late.
Yeah.
Right.
And so this is a Bacavir hypersensitivity syndrome, and rash actually only occurs in about 70% of the cases. It's the systemic findings that are the things you need to keep your eye out for. Almost everybody's going to have fever. The malaise, fatigue, myalgias, sore throat, lymphadenopathy can occur. And you don't re-challenge these people. No, they don't do well. And this is why it's an A1 recommendation to do an HLA-B 5701 test prior to starting somebody on a Bacavir.
With their consent.
With their consent, right? It's a genetic test.
Oh, it's a genetic test. There you go. Right. So by way of geography being important, this just kind of shows you the prevalence of HLA-B 5701 allele going around the world. Caucasians in the U.S., it's about 8%, lower for Asians at 1%, and African Americans about 2.5%. A point to make on re-challenge is even if we did an HLA-B 5701 test and it was negative, would you re-challenge that guy? And the answer is no, because there are probably some other alleles that could cause the same thing that we just don't have the ability to test for. The interesting thing, the HLA-B 5701 test was one of the first pharmacogenomic tests to get into widespread clinical commercial use. So definitely one of the first ones to get a niche for use. This was an excellent review in immunology allergy clinics in North America about a bunch of ARVs that we don't use anymore. So NNRTIs figure prominently there in terms of the rashes. What I put in the red boxes there was the ones that where you have to stop the drug due to a rash. And you'll notice all of them are pretty much due to toxic epidermal necrolysis, like severe skin reactions, with the kind of only exception being abacavir that has this hypersensitivity reaction that's systemic, not just the severe skin manifestation. And this I thought was just interesting, the different alleles in the populations in terms of the genetic basis for why people have the bad reactions to these different drugs. All right, I think we're almost at the end of these cases. So do I have time to do? Okay. So who wants to grab this one?
8-year-old cisgender man with HIV is an hemolytic generalized erythema and scaling. He has not been engaged in medical care for the past year, is not taking any meds. He states he has had this rash intermittently for many years.
So what do you think this is?
Seborrheic dermatitis.
So it's in terms of it being kind of immune mediated, that's on the right track. But this is a little severe.
Painful, yeah, it's a little extensive.
Yeah.
And the fact that he has not been engaged in care, does that mean he's on or off?
Probably off ART.
All right. So that was this is psoriasis. This is out of control psoriasis. And if you haven't had one of them in your clinic yet, you will see patients with bad psoriasis in clinic. So which of the following do you think is true regarding psoriasis in persons with HIV? B is 100% correct. Yeah. The incidence of psoriasis is about the same in the HIV and non-HIV population. HIV patients will respond to therapies if you escalate them like you would in other patients with psoriasis, but they're much more likely to have a more severe course and take more drug to get their disease under control. ARVs alone are not likely to, it'll improve it, but it oftentimes won't fix it. All right.
In fact, that's one of the IM board questions. If you see somebody
It
with
is.
refractory
You have to test
to
HIV.
test for HIV.
Same with
Same
seborrheic.
with
Same with sebderm. Yeah.
All right. What do you guys think of this one?
44-year-old cisgender man diagnosed with HIV 4 months ago. CD4 was 39. HIV started on ARV, returns in follow-up exam. Use rash that consists of pruritic erythematous papules associated with hair follicles in the neck, chest, back, and upper arms. Spares the axilla, hands, legs, and feet. The rash has worsened during the prior 3 weeks. He otherwise feels well. But is less than 40 copies and CD4 is 227. Skin biopsies performed showed perifollicular infiltrates of lymphocytes and eosinophils.
And the biopsy should help seal separate. Yes, it's 100% C. And so eosinophilic folliculitis not infrequently will worsen when you start ARVs, and that's kind of what happened for this guy. Within the first weeks to couple of months, you can see a worsening of this immune-mediated phenomenon, and that's what we were seeing for him. I think this is the last case.
42-year-old cisgender man with HIV and CD4 count of 54 cells seen in the clinic for a follow-up visit. He recently started taking antiretroviral therapy. His physical exam reveals scaly erythematous plaque on the scalp, face, and beard region. This is sebderm. Yeah, 100%.
And likes the beard.
C.
Yeah, topical ketoconazole. The thing with sebderm, again, it's dermatophytes like malassezia can be implicated, but it's really immune dysregulation that leads to the more severe sebderm that you see in patients with HIV. So you could call foul on me for putting a dermatophyte in with the autoimmune processes, but I think it's fair to call it immune dysregulation. Not a case, but I just wanted to, I would argue with you, this is not a dermatological phenomenon. It's an adipose phenomenon, but on the left you see some lipoatrophy. On the right you see lipohypertrophy or fat accumulation, dorsocervical fat pad, or what used to be called buffalo hump. But I understand why that's out of favor. I don't think as the patient, I would want you to call my neck a buffalo hump. The reason I wanted to make a point of saying this, it used to be thought the same way we were trying to use our Occam's razor to lump this all into one type of dysregulation of something. And the bottom line is it's not. Lipoatrophy is mostly old generation things like stavudine and zidovudine. So we don't see it too much in patients who haven't been on those drugs. Fat accumulation kind of, as many studies as have been done trying to pin down one class of drugs or one drug, really it's all been kind of not helpful. Like all we know is that people on ARVs are more likely to accumulate fat and some ARVs, it seems like in some studies, may be implicated. The bottom line is there is a metabolic dysregulation that goes along with fat accumulation. So those folks are more likely to have prediabetes, heart disease. The same systemic inflammation that we can see that the increased rates of heart disease seems to play a role in the fat accumulation. And this can cause patients a lot of psychological distress. And the federal government and many payers will pay for remediation for these things. And so it's worthwhile to advocate for your patients. Dermatology can do things with fillers for the face, and then they can have plastic surgery, liposuction. So something that you'll see not infrequently. So it's funny, patients are like very dimorphic. Some don't care, and then others are very concerned about it. And so it's important, if they're concerned, to help them get care.
Because it's stigmatizing, right?
Yes.
So, and here at the VA, I have patients that have it because those, right, they're more treatment experienced and they were exposed to those agents. And I've sent patients to derm and plastic surgery. And even though it sounds like cosmetic, it has a medical justification. So you can advocate for it. I've done it.
Now this is it in terms of last slide. I came across this Quizlet on flashcards that was a dermatologist's view on skin conditions in HIV patients. And I thought it was I liked her grouping. I liked the way she put it together. So I thought I would throw this in. It may be a useful before the board's thing to glance at. I have never made a diagnosis of HIV-associated photodermatitis, but it is a thing. I was able to find it on there. I never have diagnosed it myself.
Could you see Bacillary angiomatosis in any?
You could.
Yeah.
And that's why I'm saying these things, they're helpful as a rubric to kind of keep you keep big categories in mind, but recognize things can slide in and out.
I've seen KS in above 200.
Of course.
Yeah.
Yep, for
I
sure.
have a patient.
All right, that's it. Questions for me about any of that?